Let's go ahead and get started. I'm Valerie Cape, a program manager at CMQCC, and we welcome you to our webinar this afternoon. Next slide, please. So just a little housekeeping instructions. Go back one, Holly. All attendees are muted upon entry, and we will answer questions at the end of the webinar and as time allows. The webinar is being recorded and it'll be available from the CMQCC website within 3 to 7 business days. The slides will also be available for a free download from the CMQCC website. Next slide. So for using this slide set in the future, you're welcome to use any of the slides provided for educational purposes. And if you modify or add a slide, please substitute your institutional logo and don't use the CMQCC logos. We also recommend any of the feedback that you might have for improving this slide set. Next slide. The slide set is considered an educational resource, but doesn't define the standard of care in California or elsewhere, and readers are advised to adapt the guidelines and resources based on their local facility's level of care and patient population served, and are also advised not to rely solely on the guidelines presented here. Next slide. We are offering a continuing education for this webinar, and if you are an RN and you're going to receive contact hours, you must complete the evaluation link. The link will be sent to everyone 24 hours after this webinar. You must be in attendance on the webinar for a minimum of 50 minutes for a contact hour to be awarded. I'd like to go ahead and introduce our speakers for today. Holly Smith has been a nurse midwife for 22 years and is the health policy chair for the California affiliate of the American College of Nurse Midwives. Her background is in public health and her work is focused on midwifery integration at the state and federal levels as a key strategy for reducing disparities in birth outcomes. Holly's policy work includes various successful legislative and advocacy efforts in California that have advanced integrated maternity care, midwifery workforce expansion, midwives as abortion providers, and access to midwives for Medicaid enrollees and more. She is the lead editor of the Toolkit to support vaginal birth and reduce primary cesareans, and was the project lead for the supplement to this toolkit being presented today. Michelle Sanders has been a doula for more than 20 years. She is the founding executive director of Beauty for Ashes Maternal Wellness Incorporated and the owner CEO of Legacy Birth Pros and Legacy Healthcare Staffing. She is also a clinical lactation student and has a background in healthcare as a certified surgical technologist and a surgical technology instructor. Michelle worked with the HealthNet Doula Project, the Frontline Doula Program, and several other organizations committed to saving Black moms and babies, including the African American Infant and Maternal Mortality Prevention Initiative, AAIMM. Michelle has been an active member of AIM, where she helped to design and launch the AIM Doula program, and she served as the program coordinator for 2 years. Currently, Michelle is focused on increasing access to doula lactation support, birth worker mentorship, and workforce development. She is also one of the contributors for the supplement to this toolkit. Nikki Schuster graduated from Frontier Nursing University with a master's degree in nurse midwifery and is currently working as a certified nurse midwife at Santa Rosa Birth Center, as a freestanding birth center with physician collaboration and hospital delivering privileges. Long before becoming a nurse midwife, Nikki discovered her passion for pregnancy and birth while working with a certified professional midwife practice in Sarasota, Florida. She assisted the midwife during the labor and birth process and provided education and lactation support to the birthing parent in the birth center or home setting. Nikki subsequently worked as a registered nurse in antepartum labor, birth, maternity, maternal and newborn care within the hospital setting for over 7 years in 3 different states. Nikki is the mother to 3 loving children and a wife to a supportive husband who has seen her through many careers and passions, from theater performer to massage therapist and finally a midwife. I'd also like to acknowledge Krista Sakowski, CMQCC's clinical lead, and Emily McCormick, Program Manager at the Maternal Data Center, who will be helping facilitate and moderate the questions at the end of the webinar. With that introduction, I'll turn it over to you, Holly. And you're on mute right now.
Thank you, Valerie. And I just want to say thank you to everyone who's here today and joining us to talk about the next step in California's quality improvement journey, specifically about integrating midwives and doulas and community-based birth care. So I'm going to jump right into the objectives. Today, we are going to introduce the new content, which is part 5 now of the toolkit to support vaginal birth and reduce primary cesareans. And in doing so, we will be describing team-based care and its potential for improving the patient experience and birth outcomes, explaining the benefit of integrating midwives and doulas as necessary components of pregnancy and birth care, and also describing the value of community birth and how to promote safe, respectful transfer. Now, as you can see, these are 3 very big topics, and we could probably do a webinar on each of these, which hopefully in the future we will be doing that. So what we're doing today is really just giving you a little taste of the toolkit. Think of it like a movie trailer, and we hope that it gives you the basics so that you will go and dig a little deeper into the toolkit, which will, by the way, be available on our website later today. I also want to say thank you to a big thank you to the folks who worked on this supplemental information to the toolkit. We had a wonderfully talented, diverse group of folks, including midwives, licensed midwives, and certified nurse midwives, both doulas, doctors, nurses, public health advocates, and patient advocates who assisted with this. So thank you to them. And now I want to get first to talk about the elephant in the Zoom. And I love that phrase. It's not my own, but it's a great one. And we're going to do a little values check-in around midwives, doulas, and community birth. I actually did this recently in an abortion training, which because of the topic, you can imagine that there were some strong feelings. And the purpose of that was to talk about perhaps different issues that come up for us and biases and value judgments that we might have, in the hopes of understanding those things, understanding those discomforts, and think about why they occur and why we might have such value judgments, more or less so that we ensure that we don't bring those value judgments into the clinical space with the patient, because that alienates patients and makes them feel separated from us and leads to poorer care. So today we have a similarly hot topic. I think there are probably many people in this room right now who are very excited that we're talking about midwifery care and doula care and integrated them within our current system of maternity care. But there are probably those on the call today who, you know, even the word midwife or doula or home birth brings up some thoughts for you and maybe from your experiences, some challenges. And that's okay. We're happy that you're here today. But what I hope we consider and that you remember during this talk is that the whole idea of this, the whole reason we're doing this is because of patient-centeredness, and centering the patient is the key reason for why we're doing this. And patient-centered care, according to the Institute of Medicine and also taken up by the Institute for Healthcare Improvement, is providing care that is respectful and responsive to individual patient preferences, needs, and values, and ensuring that these patient values, their values, guide all clinical decisions. So in that vein, I'm going to talk about a few things and affirm a few things before we get into the content. The first thing is that we know that there's no singular intervention that will reduce cesarean rates or eliminate birth disparities. So we have to utilize all the tools in the toolbox. And that's also to say that we know that integrating doulas and midwives and community birth is not a silver bullet. It won't solve all problems, but they are key components of everything we should be doing right now in this space where we know the United States has the highest maternal mortality rate of high-income countries. The other thing we want to point out is that midwifery training for certified professional midwives and certified nurse midwives in the US meets or exceeds ICM standards. ICM is the International Confederation of Midwives. And we say that because we want folks to know in this call that we aren't just talking about integrating nurse midwives today. We're talking about all midwives who are licensed and credentialed to practice in the US. And that might be hard for some folks to hear again, but integration, to make that happen, we have to respect that there are multiple credential types in the US for midwives, and that we simply have different specialties. Certified professional midwives are educated and trained specifically for home birth and birth in the birth center setting, while nurse midwives are trained for hospital birth, although some do actually practice in the home and the birth center setting as well. We also want to affirm that community birth is safe when it's provided by trained, skilled providers, when risk assessment is ongoing, and when it occurs within an integrated system of care where higher levels of care can be accessed easily. And we also want to affirm that doulas are patient advocates and connectors to services just as much as they are supportive caregivers, and their expertise is desperately needed in a system that we have right now where disparate outcomes are the norm. All right, so let's take a little travel back in time to the beginning of this. The toolkit was first published in 2016, and because this is what cesarean birth looked like in California in 2014. And you can see that 40% of California hospitals had an NTSV rate at that time that met the national target of 23.9%, while fully 60% of hospitals did not. And there was quite a range there, ranging from 12% all the way up to 70% NTSV rate. So the toolkit was created, and a task force of about 50 people contributed to this. And it has been a widely used resource now, both nationally and statewide, for cesarean reduction. It has 4 key sections that are mapped out much like the AIM patient safety bundles, and that's the Alliance for Innovation on Maternal Health, in terms of readiness, recognition and prevention, response, and reporting. And now the new content on midwifery and doula integration you will find in part 5. That toolkit led to our statewide collaborative to support vaginal birth. We had 91 hospitals of roughly, I want to say 250 maternity hospitals in California. 91 of them participated, 89 with starting NTSV rates of greater than or equal to 24%. And this spanned from May 2016 to May 2019. And we conducted this collaborative in the way that we typically do under this mentor model approach, where we combine a CMQCC clinical lead with a mentor physician and a mentor nurse, together with about anywhere from 5 to 7 hospitals at a time. And these teams meet monthly, and they learn from each other and from their mentors, and they strategize on implementing the strategies from the toolkit. And in a way, they standardize care regionally without having to expressly say that. So here's what NTSV cesarean looked like during that collaborative timeframe. In that light orange box, you can see that there is a year-over-year decrease, at least until COVID hit, right? And this happened during the collaborative while the rest of the US wasn't really seeing a change. So the strategies we introduced were working. And if you're wondering what these hospitals did or how they achieved their goals, this is the list of most frequently utilized interventions. And I will say also that most hospitals used a variety of interventions and strategies, not just one. In fact, most implemented about 3 to 5 from the toolkit. And they also tailored what they worked on based on their own needs and what their data was telling them from the maternal data center. So staff education, you can see, was a big one. Also sharing unblinded provider NTSV rates amongst each other was probably, if not the biggest thing, the hardest thing as well to do. But if you look down the list a little further, you can see that not as utilized doulas and also introduction of midwives. So, as you can see from this slide, we did have good success lowering cesarean rates for all races and ethnicities, but this should come as no surprise to folks on this call that there is a lingering and persistent racial disparity. By 2019, everyone was at or below the national target except for Black birthing people. So this is not surprising given what we know about maternal mortality and morbidities in California and nationally for Black birthing people compared to their white counterparts. In fact, in California, a report published in 2021 by the California Department of Public Health using our new enhanced surveillance methodology showed that disparities in maternal mortality by race and ethnicity and between advantaged and disadvantaged groups, disadvantaged communities were actually higher than we thought. Black birthing people in California have a maternal mortality rate that is 4 to 6 times higher than their white counterparts. So clearly, we don't have equitable outcomes in California for everyone, for NTSV, cesarean, and other outcomes. And here at CMQCC, we use the definition of birth equity that was created by Dr. Joya Creer-Perry, the founder of the National Birth Equity Collaborative, which is the assurance of conditions of optimal births for all people with a willingness to address racial and social inequalities in a sustained effort. And I really want to pull out a couple words there: the willingness to address those racial and social inequalities, and to do so in a sustained way. So that means we have to do a few things, right? Achieving birth equity means we must utilize strategies that consider the root causes of disparities. And it also means that we have to consider what the community wants, what patients want in our approaches to quality improvement, because that is really the definition of patient and community centeredness. And as it turns out, the Listening to Mothers in California survey that was published by the California Healthcare Foundation back in 2018 showed that there is great community interest in midwifery care, particularly by Black birthing people. It also means that we have to have the humility to accept that what we're doing right now isn't working for everyone. The status quo isn't working for all. And it also means bringing all quality improvement pressure points to bear, as I said previously, using all the tools in the toolbox. But as we look at the quality improvement ecosystem, obviously we can't change all of the different parts at once. And particularly for CMQCC, what we're focusing on then are the clinical improvements that can be made. But there's lots of changes that have to happen to reduce birth disparities, including healthcare workforce expansion, looking at structural and institutional racism and implicit bias, payment reform, and then, of course, all the various social policies for addressing upstream determinants of health, because patients bring all of these things to the clinical visit, right? Education or lack thereof, substance use, mental health, their built environment, intimate partner violence, housing insecurity, incarceration, et cetera. And many of these things are layered. In fact, probably the foundation of this is that structural and institutional racism part, and everything kind of flows from that. So today we're going to be talking, however, about clinical improvements with these things in mind. And the clinical strategies that consider the root causes of disparities for today's discussion are team-based care, midwifery integration, and partnering with doulas. So let's jump right into team-based care. What is team-based care? We actually engage in this already. We have a really good model for team-based care in the clinical setting. If you think about how neonatologists interact with pediatricians or their outpatient pediatricians, or how obstetricians and family practice folks and nurses interact together. So we do have a concept of this. It sometimes feels like, though, when we bring midwives into the picture and we're talking about team-based care amongst physicians and midwives and nurses, somehow we lose the memory of what team-based care really means. But basically, it is a model of care that strives to meet patient needs and preferences by actively engaging patients as full participants in their care, while encouraging all healthcare providers to function to the full extent of their education, certification, and experience. It also means that relationships are governed by negotiated shared norms and visions. So if you think about that, negotiated means that there's a partnership here, and these things take time to establish. It's also where each team member has the knowledge and skills that contribute to the work in order to do the problem solving that's the purpose of the team. Now, this is not just our definition here at CMQCC, but rather this is ACOG's definition from Collaboration and Practice Implementing Team-Based Care. This is a wonderful document, a beautiful document. I don't know who wrote it except to say that it's from ACOG, but it is a great first stop for you if you are integrating midwives into your practice or into your hospital setting, or you just want to dig a little bit deeper into what team-based care really means. This is a great place to start. As with any philosophy, there are key principles to team-based care. All of these are really important. I'm not going to read through this full list, but we can't really do one without the other. However, I do want to focus on a few today that are probably the most difficult for folks to understand if you're new to this space. The first is that the patient is the integral core of the team. I said earlier, all of this is about patient-centered care, and that is indeed the case. The patient is a team member. They're the core of the team. In fact, they are the team lead. The team has a shared vision, and this is really where department leaders are key in crafting this shared vision. And in the case of cesarean reduction, from a birth equity lens, often this means intentionally cultivating a culture on the birthing unit that values normal birth and reduced intervention, and standardizing clinical processes that show that, like mobility in labor or continuous labor support or intermittent auscultation and so forth. So the team really has to have a shared vision to know what you're working towards. Role clarity is essential to optimal team functioning. So this means that I know what my role is, and I also know the limits of my role, and you also know what my role is and the limits of my role and your role, and we can seek each other out in a shared way when we need each other. And finally, this one is probably the hardest of all for folks to understand, but ACOG says that team leadership is situational and dynamic. So basically, their definition is that the team lead is the person whose expertise and training most matches what the patient needs in that moment. This can be hard for folks to understand, especially coming from the medical model that often believes that physician-led care is the best kind of care. The American Medical Association believes that. That's not something that we share because it just doesn't make practical sense. We have a shortage of physicians across the US. We also now have different kinds of teams emerging in this post-COVID world where we have lots of telemedicine, lots of AI medicine occurring. We are creating teams that have to function differently. I also want us to note that team leadership is dynamic. It means that it can change between professionals during that interaction with the patient. So flexibility is key. All right, that was a very, very quick drive-through of team-based care. I hope it gives you a little snippet of what's in the toolkit and that you will dive into that a little bit deeper. Moving on, I also want to say though, team-based care is not midwifery integration. Team-based care is one component of midwifery integration, a necessary one. All right, let's start with midwifery care. The midwifery model is a standard in all countries that have better birth outcomes. As you can see by this graphic, shows everywhere from Netherlands on up to Germany, Norway, Sweden, that their proportion of midwives to obstetricians looks a lot different than ours. Patient empowerment is a central theme of midwifery care. And that's because we believe in whole person care that considers all of the patient's needs, from their physical to their emotional, those social determinants of health we talked about previously, their personal values and wants, and their cultural needs. The World Health Organization defines midwifery as the skilled, knowledgeable, and compassionate care for childbearing women, newborns and infants, and families across the continuum through pre-pregnancy, pregnancy, and birth and postpartum, and through the early weeks of life. And in the US, we also know that midwives care for patients across the reproductive lifespan as well, not just pregnancy and birth. The task force in this toolkit really thought it was important that we describe for you, if we were to package what midwifery is, or to talk about the secret sauce, to put it another way, how could we put it into a nutshell to define it? And in a nutshell, midwifery philosophy has long preserved three immutable elements, and those are patient-centeredness, the therapeutic use of the human presence, which is, I think, just a beautiful quote, and non-intervention unless necessary for the health and well-being of the pregnant person or fetus. And that quote above is from a Green Journal article back in 2016 called Making Room at the Table for Obstetrics, Midwifery, and the Culture of Normalcy within Maternity Care. And that is also a really great starting point, and it is in the toolkit if you want to advance your knowledge about midwifery integration, both in the hospital setting and across to community settings. And we talk about more in the toolkit as well around the pearls of midwifery, how they align with ACOG's recommendations for reducing interventions. So there is more there in terms of the secret sauce, if that's what you're looking for. The benefits of midwifery have been well established, so I don't want to take up too much time talking about these. Because we're well aware of them: lower cesarean birth rates, lower operative vaginal birth rates, lower NICU admission rates, higher rates of spontaneous vaginal birth, TOLAC, VBAC, and lower cost. What I do want to spend a little bit of time on, though, is midwifery certification in the United States, because we do have a couple different routes by which people become midwives in the US, and this can be confusing sometimes. There is much more on this in the toolkit, but in short, there are a couple different routes. First is for people to go through the nursing route and then their midwifery training. And these are certified nurse midwives who are certified by the American Midwifery Certification Board. And then there's also something called direct entry midwifery, where midwives enter the profession without the nursing training, so it is distinct from nursing. Certified midwives are one kind, and they are also certified by the same certifying board and agency as certified nurse midwives, and also have the same professional organization, the American College of Nurse Midwives. Certified professional midwives enter midwifery directly as well and are certified by the North American Registry of Midwives, or NARM, and their specialty is community birth. However, if you get down to the state level, you will find that there are different requirements and components for statewide licensure. So the toolkit does lead you to where you can go to look more into the different midwifery credential types, education, scope of practice, certification, as well as California specific stuff, because in California we have nurse midwives and licensed midwives, and what their licensing and certification and scope of practice is all about. And it also will give you some information on the global standards and policy and practice. So now let's talk about community birth. Community birth is home birth and birth in freestanding birth centers, and people who choose community birth do so for a variety of reasons, often based around their intrinsic values and preferences. Sometimes there's cultural practices involved, or simply the desire for reduced intervention. And some may even have had a previous traumatic birth experience in the hospital setting. The safety of community birth is well documented. One study that comes to mind most recently is a study from 2021 by authors Elizabeth Nethery and Aaron Coy and Vivian Suter and a few other people whose names I'm forgetting at the moment, that looked at community birth in Washington state, which happens to be the state that is the most integrated in the US. And what it showed was the absolute risk of adverse outcomes were very low. Birth outcomes were similar for births planned at home or at state licensed freestanding birth centers, and even that perinatal mortality rates were identical to the rates of perinatal mortality cited by ACOG as the benchmark rate in hospital settings. So this is one study of many, but it's very recent. It shows what can happen in an integrated, well-established system. But I do have to say that safety studies in community birth in the US are complicated by study quality and by difficulty of interpretation. There's also at times flawed methodology. The studies vary in their rigor and so forth. And because of that, professional viewpoints on community birth, maybe even your own viewpoint on it, have been informed by certain lower quality studies that were older studies that unfortunately formed the basis of ACOG and AAP's position statements on home birth. But a couple places you can go in the toolkit to find out more about the safety of community birth. One is the Birthplace Lab. If you have not been to that website, you should, because it is a wonderful resource for research. Particularly, they have the Rescue Index for evaluating the data quality of home birth studies, as well as an annotated guide to the literature that walks you through a ton of studies from recent to way back in the past, and their methodologies, statistical analyses, and so forth. I would also point you to the Strong Start study for mothers and newborns, which is also in the toolkit, which was published a few years back. That was a study over about 4 or 5 years' time that compared enhanced models of care, including birth centers, group prenatal care, and maternity care homes. And as it turns out, people who received prenatal care in the enrolled birth centers far and away had better birth outcomes and lower costs in terms of preterm birth, low birth weight, and cesarean birth rates. So again, this is just a taste, a little movie trailer of what's available for you to find out about in the toolkit. But what these studies, all of these studies put together, tell us is that community birth is safe when there is appropriate risk selection and ongoing assessment. 2, when it is well integrated into a system of maternity care that connects all birth settings. And by that, we mean that there is easy access to consultation and collaboration when a higher level of care is needed. And when there is transfer that is efficient, respectful, and seamless across settings. And also when birth attendants meet the training and competency standards of the International Confederation of Midwives. So to that end, the toolkit includes many community birth resources for you, including integration improvement resources, transfer improvement resources, continuing education for improved community birth integration and safety, and also real clinical stories from California, stories and vignettes that amplify the strategies outlined in the toolkit. I just want to give a call out to our partners over at Purchaser Business Group on Health, who have been working on integration of midwifery care for many years now. And over the last couple of years have engaged in a multifaceted initiative to improve hospital birth center collaboration in California. And these initiatives have resulted in a large compendium of both new and tested resources to improve safe and efficient and respectful community birth. And so I put the link here, and you can go there and find a transfer planning template that was designed by a group of experts in California for hospitals and birth centers to use as a template to create a plan of action for community birth transfer. And you can see from the slide here, there's many more integration resources. And forthcoming will also be a hospital guide to integrating the birth center model of care, as well as extensive transfer guides and resources from other states who have done this before us, like Washington's Smooth Transitions Program, Oregon's Community Birth Transfer Improvement Toolkit, and Utah's Perinatal Collaborative as well. This is just an example of one of the continuing education links that are available in the toolkit. This is one of the best I've seen. It's from Hive CE, and it's an interprofessional continuing education to support smooth transfer from planned community birth to hospital. And they have modules for both midwives, EMS, and also specific ones for the receiving hospital. So what does midwifery integration look like then? We've talked a lot about it, but we haven't defined it. And that's because actually it's kind of hard to define in a nutshell. A few years back in 2018, Saraswati Vidam and folks at the Birthplace Lab published a landmark study that gave us a basic policy and clinical components of midwifery integration, and they looked at it in all 50 states and compared all 50 states. And we took that and in this task force expanded upon what midwifery integration might look like. I'm not going to go through all of these right now, but I do want to point out a few really important ones. Excuse me. One is that there is a culture of interprofessional partnership, meaning easy access to physician and medical consultation and collaboration as needed. Another one we've already talked about is that there are guidelines in place for safe, efficient, respectful transfer, and that these are created through a collaborative process. Also, that state scope of practice laws allow for midwives to practice to the full extent of their education and training. We're not there yet in California, but hopefully that will be the future. And where reimbursement is equal across provider types so that midwives can keep the lights on, right? And there's equitable coverage for midwives and birth centers by all payers so that patients can access midwives, and it's not just the folks who can pay out of pocket for it. You can also think about this in the reverse. You might have a lot of good things happening around midwifery integration, but it hasn't fully been achieved if some really important things haven't happened yet. So here are a few examples. One, if midwives are privileged at your facility, but they function only as physician extenders. For example, they can't admit or discharge their own patients, or they require their notes to be co-signed. That's not integration. It's also not team-based care that I talked about earlier. Or where hospitals in your region refuse to take community birth transfers. Or where you or your hospital culture is okay with hospital midwifery, but uncomfortable with community midwifery. Or where insurers don't cover community birth, as I was saying earlier, so midwives are not easily accessible to everyone. So to that end, we have a giant list of strategies for midwifery integration in the toolkit. They are for hospital-based providers mostly, and for providers, nurses, and administrators. It's divided into administrative, educational, and clinical strategies for your setting. I want you to really dig into this as one of the first things you do when you read the supplement to the toolkit. But a few things that we talk about are things like, well, number one, if there are no midwives at your facility, to hire or contract with midwives to establish a team-based model where you're at. If you do have midwives in your facility, encouraging them to lead quality improvement efforts, especially those efforts that promote low intervention care to improve outcomes. Foster a departmental culture that values reduced intervention for low-risk birthing people. And here's a game changer. This one's important, and Nikki Schuster will be talking about this a little bit later about Santa Rosa Birth Center. But having or privileging community birth midwives in your facility to enhance continuity of care and the seamless transfer. Many people don't know that only about 10% of community births are transferred to the hospital during labor, and only about 1 to 2% are emergency transfers, meaning transferred by ambulance. The others are transferred by car and are typically due to things like protracted labor that need a little Pitocin, or perhaps the person wants the next level of pain relief. And in those cases, those folks can remain in midwifery care if those community birth midwives were able to do so. So thinking about privileging those folks at your facility. Improving systems that facilitate the safe patient-centered transfer. And to that end, we also in the toolkit have an entire list of strategies to do just that, to improve integration across settings. And we utilize the expertise of our task force, as well as a variety of other state resources from other perinatal collaboratives and community birth organizations. And they include things like promoting timely access to consultation and continuous risk assessment. And this includes not just in the time of labor, but in antepartally and postpartally, to be able to have that access to consultation. It means also implementing elements of just culture when responding to an emergency community birth transfer. So regardless of the emotions in that moment, treating each other with respect and compassion. Again, giving a shout out to privileging community birth midwives at your facility. And respecting patient autonomy, and doing so by destigmatizing the choice to safely birth at home or in a birth center. And there's a few basic ways. Words matter, number one. And a few basic ways we can do that is referring to community birth as community birth, not out of hospital birth, because out of hospital kind of sets the stage for what is the accepted norm. Not referring to non-nurse midwives as lay midwives, because that really devalues their education and training. And finally, not referring to home birth transfers as a failed home birth or a failed births. Don't write that in, don't put that in your notes, and don't say that to the patient. A home birth transfer or birth center transfer is a right care at the right time approach, meaning the patient didn't need medical care before, but now they do. and they're being transferred to the hospital to get such care. It's kind of in the same way that we don't talk about cesarean birth as a failed vaginal birth, right? We give it a different name because it is something different. And here's one of the most important: holding joint learning opportunities such as debriefs and grand rounds and meet and greets for providers across settings so that you can deepen relationships and improve that care coordination and create shared expectations. And that's not just a pipe dream, that is actually happening, particularly in the North Bay in Northern California. Birth Bridges, for example, is a perinatal collaborative, which is a collective of community midwives and doulas and hospital midwives, physicians, and more, who are working together toward a seamlessly integrated system of care. Particularly Alameda Health System and Zuckerberg San Francisco General have been involved in this, and they're doing so specifically to address those disparities in perinatal care and outcomes. So this can happen, and if you're wondering, you want more information about that, you can always email me and I can put you in touch specifically with those people. So with that, I am going to turn it over to Nikki Schuster, who is filling in last minute for us to give a profile of the Santa Rosa Birth Center. So thank you, Nikki, for being here.
Thanks, Holly. So first, I just wanted to give you a little background on how I came to be at Santa Rosa Birth Center and perspective on why I sought out that kind of practice. I became involved with care and labor and birth as a midwife assistant for a certified professional midwife at a freestanding birth center and a home birth practice. In fact, it was one of the birth center practices that was included in the Strong Start study due to its very high Medicaid patient population. The practice was long-standing in the community, had excellent outcome statistics. The midwives had a collaborative physician who signed off on protocols and clinical guidelines, and there was a very clear method for risk assessment throughout care. But there was a distrust of midwives and a misunderstanding of community birth amongst the physicians and the nursing staff at the surrounding hospitals. And this really led to disorganized and uncollegial intrapartum transfers of care, where upon arrival, hospital providers and staff would refer to these as train wrecks. So it led really to patients feeling like they no longer had autonomy of care. The midwives often weren't allowed to accompany the families into the hospital setting, and the birthing patient was often met with hostility and judgment by that receiving care team. It was a very uncomfortable situation, and this breakdown in collaboration between the birth settings really only served to perpetuate a broken system. So when I became a nurse midwife, I really sought to be a part of that solution. And I joined the team at Santa Rosa Birth Center, particularly because of how they had integrated into the community. So a little background on the birth center at Santa Rosa. In 1993, Santa Rosa Birth Center, or SRBC, as I'll probably refer to it from now on, was established really with the intent to provide community-based midwifery care to families, regardless of their ability to pay. And today, that payer mix is roughly 85% Medi-Cal, 15% commercial insurance, and less than 1% private pay. Last year, SRBC had a 9% hospital transfer rate and an NTSV cesarean rate of 11%. The patients who seek care with the midwives at Santa Rosa Birth Center may choose to give birth at the birth center if they're essentially healthy and low risk, or they can choose to birth at the hospital because our midwives have privileges at 2 of the 3 birthing hospitals in Santa Rosa. This arrangement really promotes safety for our transfer patients. It supports physiologic birth across birth settings, and it maintains that continuity of care even after transfer. In fact, the majority of SRBC patients who transfer to the hospital do so for reasons that aren't emergent and that remain within the scope of midwifery-led care. Things like the need for pain management, or prolonged rupture of membranes, labor augmentation, or even post-dates induction. In addition, there are lots of families who seek care at the birth center who want that midwifery-led approach to prenatal care and education, but they may not be candidates for community birth due to their risk factors, or they simply may want a hospital birth for their own sense of comfort and safety. So having hospital privileges for the midwives means that patients who desire midwifery care don't have to limit their options based on the location of birth. And because of this integrated model, which is grounded in respectful, collaborative relationships with physicians at these two facilities, approximately 99% of SRBC patients continue to have midwifery care regardless of their level of risk. In fact, 86% of our birth center patients transferred to the hospital give birth with their midwife. And this system, this model, allows the midwife to continue holistic labor and birth care, that human-centered piece that really is according to the patient's own needs and desires, while the physician closely manages the patient's medical condition. Our midwives at Santa Rosa Birth Center even first assist for cesarean birth. And for those patients, we also do the postpartum rounds in such a way that we can ensure that continuity of care, even for people who don't birth vaginally. It's meant a world of difference, both for a midwife perspective and for the patients and families, to know that the person they have had hold their hand through the entire process continue into the operative birth. And when midwives remain a part of the team to act as this bridge between providers or birth settings, the patient's experience is better and it's safer in the most emergent transfers. So the motto of SRBC is, what makes community birth safe is knowing when it's no longer safe. The hospitals where we deliver care understand that transfer is an extension of the right care at the right time philosophy. And as the hospitals worked to establish an integrated care model to improve and streamline community birth transfers, it became clear to them that when midwives are able to transfer patients easily and remain an active part of the care team, the transfer happens earlier, the patients are more at ease, and outcomes are not compromised. It took a lot of time. And yet everyone involved moved away from this us versus them mentality. And it really allowed the nurses and the providers at the hospital to become an extension of the birth center, because the midwives are considered part of that integrated team that functions across the settings. The Santa Rosa Birth Center care model was deliberate and was established over time, took many years and building of relationships. One of the major ways that we did that is that we created a culture of antepartum consultation with our physicians at the hospitals that functions more of like an open door policy. So at any moment that we have a question or want to have a conversation of patient care, it is comfortable to reach out and do so. And this developed a really trusting working relationship with the intentional effort to accept each other's different management styles and perspectives, knowing that we all have our expertise. And this consultative relationship in the antepartum period has also led to a system of ongoing risk assessment that really works. So of the patients who risk out of giving birth at the birth center in the community setting, the vast majority do so during that antepartum period, lending to superb outcomes for the patients who give birth with Santa Rosa Birth Center midwives, regardless of the site, and an emergency transfer rate less than 1%. So to make this model work, It's already been mentioned. What do we need? The key tenets of team-based care, which have to be considered, would be that patient-centric care. Having a shared vision between the different facilities, providers, and community, having clear role clarity about what are the expertise of the different providers, respectful communication. That can be challenging, and it takes practice sometimes. And then that situational team leadership, knowing that the one who has been caring for and been with the patient is the one that continues to be the lead in that care, unless a full transfer of care is needed. I hope that this little piece of information about our birth center can be helpful for other communities. And thank you so much for letting me be involved.
Thank you, Nikki. That was very informative and very helpful. We appreciate you being here today. So we are going to now move on to partnering with doulas. So what is a doula? First, I should say, though, in California, we have a huge collective of doulas statewide that have really been working on partnering with doulas for many years now. A large range of advocacy groups who, in fact, have now established that in the coming year, that reimbursement through Medi-Cal will be available to doulas in California. So that's a huge success, and this work has been ongoing in California for quite some time now. But what is a doula? A doula is a trained non-medical professional who supports and protects the patient's physical, emotional, and informational needs during labor. Doulas also have an important role during pregnancy and especially postpartum, when we know the majority of maternal mortality cases occur, especially in recognizing symptoms in patients that need to be addressed by a clinical professional. Some doulas provide support during and after miscarriage or before abortion. And there are even end-of-life doulas on a totally different track who support people in hospice or at other times as they prepare for end of life. The benefits of doula care are probably well known amongst this group as well, so I'm not going to read from this list, but do go to the toolkit if you are wondering what those benefits are. The toolkit has like 458 references, so you can be sure that we we covered everything. And the benefits of doula care are listed there, and you can find the resources for that. But there is an impressive 39% less likelihood to have a cesarean birth with people who have continuous labor support, such as doula support. And the ACOG SMFM obstetric care consensus statement says that the published data indicate that one of the most effective tools, and I love that they say that one of the most effective tools to improve labor and delivery outcomes is the continuous presence of support personnel, such as a doula. So again, getting back to that therapeutic use of the human presence. So given that there are no associated measurable harms, this resource is probably underutilized. This graphic here is also in the toolkit, and it comes from the, it's an adaptation from the AIM doula program, which put together a list of what doulas do and what doulas do not do, just to make it very clear, and also so that we are still clear that midwives and doulas are separate professionals. Doulas are involved in prenatal teaching and childbirth education, giving comfort care and physical support, but they also are really involved in giving culturally congruent advocacy and informational assistance. They also preserve and support respectful care and privacy and dignity. Really, these doulas are the protectors. They are, if you're a Mr. Rogers fan, and he always said, find the helpers, doulas are the helpers. They are the advocates, and they're there to help you as the professional and the patient as well. They typically remain with the patient throughout the golden hour, so throughout labor and into the golden hour, although there are other kinds of doula programs like that work in a collective that may take turns during a particularly long labor, but mostly they will remain with the patient throughout. Doulas do not, however, provide clinical care, such as physical assessments or catching the baby. They don't do nursing care or fetal monitoring. They, of course, do not diagnose conditions or give medical advice, and they don't or should not make decisions for the patient or pressure the patient into certain decisions. There are various types of doula programs. Today, we're going to talk about what we concentrate on in the toolkit, which are hospital-based doulas and then community doulas. Hospital-based doulas are exactly what it sounds like here, typically are volunteer programs. One in particular in California and Southern California, which we outlined in the toolkit, is at UCSD, University of California, San Diego, that has had a volunteer program now for 20 years. And they are able to provide doulas for folks who either can't afford it or don't have a doula in labor or don't know about doulas or can't access them. So they are an important stopgap and are considered a part of the care team at UCSD. And then there's also community doulas. As you can imagine, community doulas are from the communities for the patients they serve. And what this graphic is intended to depict is that, every community has different housing, different schools, different access to food and groceries and the built environment. And so community doulas really know that best and bring that to the interactions with patients from the same communities. Michelle is up next to talk about the AIM doula program. And I have heard her say in other webinars, and I hope she says again, that when she shows up as a care provider or as a doula provider for a patient, she's bringing the whole community with her. And by that, I assume she means that she's bringing that innate knowledge of what that person needs and values to that interaction. So the toolkit has as well strategies for partnering with doulas, and they are again divided into the administrative, educational, and clinical strategies. And here are a few. One, very important, connect with community-based doula programs and show interest in supporting and welcoming them into your facility. And if you're wondering what programs are in your area, email me or Krista at CMQCC, and we can find those folks for you. Doulas should be empowered to remain independent champions for patients, even if they are part of a hospital-based doula program. Hospital policies should reflect that doulas are not visitors in the traditional sense and not bound by the time limits or other visitor rules. Like this is something we particularly learned during COVID. Again, intentionally cultivating that culture on the birthing unit that values physiologic birth. Updating our policies to include doulas as support people in the operating room if the patient desires. And a really important one, creating opportunities for interprofessional education, much like the Birth Bridges program is doing that I spoke about. That includes doulas from your community or a doula organization with whom you have a relationship. So you can learn from them and they can learn from you. Those are just a few. You'll have to go to the toolkit for more. And with that, I'd like to introduce Michelle Sanders, certified doula and the previous program director for the Los Angeles County African American Infant and Maternal Mortality Prevention Project, specifically for the doula portion. Thanks for being here, Michelle.
Thank you, Holly. Good afternoon, everyone. It is a pleasure for me to be here and share with you all today. And as Holly mentioned, yes, I am a community doula, and I absolutely bring the entire community with me when I show up for my clients, for births and for postpartum. And that really does reference the fact that because I'm serving the community that I'm from and bring my lived experiences, then we are connected to the resources that are best suited to fit the needs of these families that we are serving. And so that's what I mean by that. But to start, I'd like to share a little bit about the Los Angeles County Department of Public Health AIM doula program. So again, AIM is the African American Infant and Maternal Mortality Prevention Initiative. So we use the acronym AIM for that. And so the AIM doula program launched in 2019, for which I served as the program coordinator for a little more than 2 years. The AIM doula program is a part of the Broad AIM initiative, which is a county-wide initiative, and their collective mission is basically to address the high rates of Black infant and maternal mortality and to ensure healthy, joyous births for Black birthing families in Los Angeles County. In its first year, the AIM Doula program served well over 350 birthing families, and that is thanks largely in part to the hard work and dedication of the inaugural cohort of 14 Black community doulas. So basically, what we had was a program that was for Black families, and the workforce was 100% Black African American doulas. So a lot of times, just something as simple as having a support person who looks like you, who shares your lived experiences, your values, and also some of your struggles and traumas in life can make a huge difference when it comes to, your birthing journey. So some of the things that I want to talk about today are those disparities, specifically for BIPOC people, and how to improve birth outcomes, because this is a long-standing priority for me, and it really should be for all of us, right? Because no matter who you are and where you come from, there is one thing that we all have in common, and that is birth, right? I think we can all agree that we have that in common because we were all born, right? So it may have been vaginally, it may have been via cesarean, but no matter what, we were all born. And the birth experiences have a significant impact on a family unit. They have a significant impact on the baby, on the parents, and on the family unit as a whole. And so these birth experiences can either positively or negatively impact a family's trajectory for generations. And so a lot of the work that we do is to help ensure that families are having more positive birth experiences and less negative birth experiences. So case in point, when we talk about negative experiences, for over 400 years, racism has wreaked havoc on Black families. And that same racism is what still undergirds the unacceptable disparities that still persist today. And so, you may have heard me speak before about racism being the root cause of the disparities that we see in Black birthing communities, and that is still the case. And so when we talk about what we can do to eradicate some of these disparities and the maternal and infant mortality rates in the Black community, obviously anti-racism trainings and implicit bias trainings and things like that are, crucial to addressing what is happening and how do we make changes to see the results that we want to see. So that's the question, what can you do? What can we all do to be a part of the change that we want and really need to see? So for starters, we've seen an increase in awareness and also funding dedicated to improving birth outcomes in recent years, but we still need to continue to raise awareness. A lot of people don't know about the disparities that exist. So sometimes when they hear us speak about it, it's their first time hearing about it. They're shocked to know that Black women and babies die at alarmingly higher rates than their white counterparts. So we need to continue to raise awareness and also advocate for more funding to support the work of grassroots community-based organizations, the ones who have been leading the charge for decades. So instead of reinventing the wheel, let's prioritize funding the organizations that have already been doing the work. We have so many community-based organizations, so many community doulas who are here and ready to do the work, to answer the call, but a lot of times the barrier is finances or funding. So funneling the funds to the organizations that have been making changes, that have been doing the work, is another way to make sure, we see these changes that we are looking for. So another way that we can support healthier outcomes, reduce cesareans, and more positive birth experiences is to cultivate an environment that welcomes and supports the presence of community doulas at your facility. So myself, I am a doula, but as mentioned earlier, I'm also a certified surgical technologist. So I'm very comfortable in the hospital, particularly in the operating room. I worked in labor and delivery, so my job was to assist in cesareans all day, every day. However, what I noticed while I was there was that a lot of times there was not adequate support in the operating room. And so there's a few reasons why. So sometimes, unfortunately, the partner, the father, other family member just was totally uncomfortable with being in the operating room. Or sometimes there are policies that prevent a doula or support person from entering the operating room. So one way we can address that would very simply be, let's revisit these policies. Let's see what we can do to make sure that every birthing person is supported, even in the surgical birth, so that no one is alone during a birth, number one, and you have someone there again who is that person who's committed to you, that person who has not changed during this whole birthing journey. A lot of times, as doulas, what we offer is that continuity of care. You know, shift changes at hospitals. Births can be hours and days long. And so, you know, there will be different clinicians throughout this journey. However, when a person has connected with a doula during their pregnancy, more than likely that doula is going to ride it out with them. As Holly mentioned, sometimes, you know, there is a change for prolonged births, but for the most part, as doulas, we like to finish it out with our clients. And so making sure that doulas are welcomed in the facility, making sure that doulas are viewed as a valuable part of the care team is another way that you can help integrate doulas into the care that you are already giving to the clients that you serve. And so when we talk about reviewing policies specifically, what I want to say, the important part is not just to review the policies, but to also get input from, again, the grassroots organizations, the community doulas, some of the families even that have come through your facility. So to get input to see what actually is needed and what they want versus just making decisions based off of what, you know, we may think is needed. And so including the community in your review and then in that decision-making process, I believe will yield better results, better policies that will make doula support more accessible to families and also to uplift the value of doulas. Obviously, I'm a little biased because I am a doula, but I highly value doulas and the work that we do, and I've seen the impact over and over and over again. If you are considering a hospital-based doula program, or if you already have a hospital-based doula program, again, the shared decision-making is important. Also, the autonomy is important. You know, maintaining the autonomy of the clients to choose their doula is very important. So sometimes what we see is a hospital-based doula program that doesn't necessarily welcome clients bringing in their own community doula. And so we might want to revisit that also, just to see if we can make this more accessible for everyone and maintain the autonomy and the integrity of the work of doulas.
Michelle, this is Valerie. Excuse me. I just wanted to give a time check.
Okay.
I don't know how much time we'd like to leave, just a few minutes for questions at the end.
Thank you. Just
Thank you.
One more point, Valerie. And so encouraging bidirectional learning and support is also another tip or another useful tool that I feel will yield better results for parents and families. So clinicians and doulas together, debriefing, talking about what we saw went well, what could be improved upon, I think will foster a culture of, you know, better support for parents and reap better benefits. So in closing, I just like to say, instead of us doing what we've always done, let's think about, like, you know, thinking outside of the box and doing what really is the best for birthing people to be the change that we'd like to see. Thank you, and I will send it back to Holly.
Thank you so much, Michelle, for that. We want to now jump into, well, first I will say, you can, after this webinar, reach us if you have data center questions at the data center email here. Clinical improvement questions or questions about the toolkit can go to Krista, and her email is listed. And questions about midwifery and doula care in California can come to me, and I will send them to the right people as well. There are a lot of questions in the Q&A about the multiple layers of systems changes that need to occur in order to enhance and fully realize midwifery integration, such as Medi-Cal reimbursement and other issues. So if you have those policy questions that are separate from the clinical stuff we're talking about today, please email me here at holly@midwiferyrising.org, because there is a ton of midwifery integration happening across the state on those policy topics. And I'd love to get you in touch with the information that you need. There is a question here about doulas that I want Michelle to answer. And then there is also a question in the chat that was really important about how we kind of realize how we actually make team-based care happen on the unit, and quote, who is in charge and how does that all work? And so I'd like to answer that. But first, let's go to the question about doulas, which says, can we talk about requiring doulas to have certifications, which may detract from community knowledge, who may have not had access to the resources to doula certification processes, especially speaking from an equitable lens? So I think the question is about, does it create barriers if we are requiring doulas to have certain certifications?
Short answer is absolutely yes. You know, we've seen this time and time again. It does create barriers requiring certifications from certain organizations, right? There are a plethora of doula training organizations. However, there are some that are held in higher regard than others. And those are the organizations that some facilities require doulas to have. And so sometimes finances are a barrier to doulas receiving that certification. It costs to go through the training and subsequent certification. And sometimes it's just not a good fit. It's not in alignment with who we are as community doulas. And so we choose not to certify with these organizations. And then that can pose a barrier for us to be able to attend births at a certain facility. And so with all that being said, I'd like to say there is no national certifying body for doulas, right? And so these organizations that offer certification are just organizations that say we certify doulas. And so there's no reason to hold one in higher regard than the other. I think we should equally welcome certifications from community organizations or, you know, these other larger organizations, and understand that as doulas, we show up with a lot of different lived experiences and really prioritize that over certification.
Appreciate that, Michelle. Thank you. There was another question that says, so a team-based circle leadership versus medical hierarchical, how do administrative oversight of clinical staff and protocols work? Who is ultimately in charge, especially when the midwifery model of care diverges from obstetrical model of care and with patients with elevated risk histories? Oh, apologies. I need to start my video. Thank you, Valerie. So this is a really good question. So I think I would start by saying that the team-based collaborative model is one that is built over time. And it's really built on what Nikki was saying, those functioning relationships where you trust each other. And each part of the team also knows their individual limits. I go on to say in the Q&A that this is much like how generalists know their limits as it relates to a patient needing specialist care. And we also want to say that none of this is easy, of course. It takes time to build these kinds of clinical teams, and it takes clinical champions and a coalition of the willing to begin this process. A really great resource that is also available in the toolkit are the collaborative practice papers, the collaborative practice winning papers from ACOG and ACNM, and you can even Google it and you'll probably find it. And in there, you'll find 2 winning papers from California practices, including Sutter Davis and San Francisco General Hospital, who have this collaborative team-based models. And those questions around leadership and oversight and who's in charge and how does it all work are really outlined really beautifully in those papers. So I encourage you to go there. We also have a fair amount of open questions. We've answered a lot of them. If you have more questions and you desperately want them answered, please do not hesitate to contact Krista or I. Krista more for the clinical side of things. If you have more policy questions and those other layered issues occurring in the policy space, please feel free to contact me.
Thank you, Holly, and thank you, Nikki and Michelle, for a great presentation today. We really appreciate your efforts and the information you've been able to share. Again, the recording will be available on the CMQCC website in the next 3 to 7 business days, and the slides will also be available. The new supplement to the toolkit will be on the website shortly, if not later today, probably tomorrow. And if you have any questions, please let us know. Thank you for joining us today. Have a great afternoon.